Welcome, everyone. I'm Karin Hehenberger. I'm the CEO of Lyfebulb, and I'm here together with Dr. John Crew, as well as Shelby Hansen. And we're joining me today for a seminar focused on post-transplant experiences, expectations. And we're very grateful to CSL Behring for the support for the seminar series that has been focused on clinical trials and innovation in the transplant space. So it's really a unique setup, I think, in the sense that we have an expert, a medical expert in Dr. Crew, as well as a person who's really experienced kidney transplant herself. I want to add that I'm a moderator, but I'm also someone who has experienced a kidney transplant. So I will kind of try to go between and obviously let Shelby lead the discussion from a patient perspective. We want this to be interactive. We have collected a number of questions ahead of time from our audience, from our community, but we are also open to receiving questions from the audience during the session, and I'll try to funnel those questions back. And if your question is not answered in this session, they will be answered over time. And this is also archived, recorded, so you can go back and listen to it. So let's start. I want to start with you, Dr. Crew, and really just get the expectation. You are getting a kidney transplant. What's the timeline? How long are you in the hospital? And over the next 12 months, what's really the sequence of events when it comes to getting back to that new normal that the patients so very much crave to be able to be in real life again?
Sure. So the expectations in the hospital depend a little bit on the type of organ. And I say that because live donor transplants tend to recover a little bit faster than deceased donor transplants. And so starting with the hospital stay, with a live donor transplant, you pick a day. Next Tuesday, you come in and you get your operation with your living donor. Our patients will then, after the operation, go to our transplant floor. And for the first 4 days, they're receiving intravenous medication to help suppress the immune system. And some of those medicines that we give intravenously actually hang out in the immune system for several months. So they actually help prevent, even though we've only given them for 4 days, they actually last and have a lasting effect on the immune system.
So just to interrupt, those medications that you're giving over the first 4 days are different than the ones that are given to the patients for the rest of their life.
Correct. And so this is in addition to the pills that people take for the rest of their lives. We give additional medication because, unfortunately, with kidneys, the risk of rejection without these drugs is actually pretty high. If you just gave the pills, because we tried this in the 80s, early 90s, if you just gave the pills, the rejection rates were as high as 40%, 45%. We give some additional medicine through the IV to help suppress the immune system for the first 3 months. And now rejection rates have gotten down to 8%, 10% with live donor transplant. So it's extremely effective medication, but it has to be given through the IV, has to be given in the hospital. And during that time, as while we're giving the medications, you're also beginning to go back and start resuming your regular diet. We're doing an operation on the bladder. And so when you're hooking up a ureter into the bladder, patients also come out of the operating room with a Foley catheter to help drain the urine. Many of our dialysis patients have made no urine or little urine for years before they get their kidney transplant. And so sometimes the bladder is a little bit small and it can take a little bit longer to heal and grow to normal size. And so here, at least, we keep that Foley catheter in for the first 3 days. The morning of the 3rd day, we take out the catheter to make sure that patients can urinate on their own. You can imagine if your bladder is very small and all of a sudden you have a new kidney that's putting out several liters of urine a day. At the very beginning of the transplant, we expect everyone to unfortunately have to urinate every 30 minutes, every hour. And over the course of about 2 weeks, 3 weeks, the bladder actually grows and comes back to normal size. So our average stay for a live donor transplant is 4 days. And as I mentioned, during the time you're getting intravenous medicine, you're being started on your transplant pills. You're beginning to advance your diet. We expect people to walk around on the day after the operation. Day 2 after the operation, they're walking further in the hallways on their own. Day 3, that catheter comes out, and we expect people to become mostly independent, to then be able to go home. And for the first month, they come back to our transplant clinic twice a week at least once for blood test, and a separate day for blood test and to visit the doctor. Depending on how people are feeling, frequently, actually, we see patients twice a week at the beginning. Because all the oral medications that we send people home on, they have different side effects. Some cause headaches, some cause diarrhea, some cause tremors, nausea. And so if patients aren't feeling well, we definitely see them more frequently. But the bare minimum at our program is twice a week lab test, once a week doctor visit. The following month, it becomes just once a week doctor visits and lab tests. Then it goes to every 2 weeks. And beyond the third week, in terms of doctor visit frequency, it goes to once a month, at least at our center. And as the year goes on, through the end of the year, it becomes less and less frequent, such that after 6 months, patients begin to see their doctors only every 3 months. But we continue to do the blood tests every month, predominantly because with kidneys, these medicines have gotten so good that many people don't know that they're experiencing rejection or issues with the kidneys because in the past, 1980s, 1970s, when someone had rejection, it was pretty dramatic. They would have fevers, they would have pain over the kidney, they would feel something different. These days, with the medicines we have, they're potent enough that the rejection episodes people have, the creatinine will go from 1.2 to 1.5. Patient feels totally fine. It's only something that we detect in the blood tests. And so for us, the blood tests, particularly in kidney, the blood tests are crucial in terms of determining how is the kidney doing, how are you doing vis-a-vis the medications, and also the blood tests are what we use to adjust the dosing of the pills. I guess I've focused mainly on live donor transplants. With deceased donor transplants, it depends a little bit on how quickly that kidney works. Sometimes with the deceased donor transplant, we get a kidney from New Jersey and put it into a patient. It's only been out of the body for a few hours and works right away. There are other times, though, when we have kidneys that match our donors, where the donor matches the recipient and that kidney comes from St. Louis or Washington State. Those kidneys that have been out of the body for a long time will serve the patient very well, but frequently they have what's called acute tubular necrosis, a tubular injury where the kidney has to heal. And so those patients frequently stay in the hospital for a longer period of time, sometimes getting dialysis until the kidney wakes up.
And Shelby, you had that experience, correct?
I did have that experience. Yeah. I had delayed graft function after my transplant. I was living in Michigan. Somebody else got a transplant from Michigan. Go blue. But my kidney, I was also preemptive, and my kidney came from California. So it was out of the donor body for over 24 hours before I had the surgery. And so it took about 7 weeks before my kidney started to function.
So you were 7 weeks in the hospital?
No, thank heavens. My husband was also a student at University of Michigan. He was getting his PhD there. So we lived on campus housing. And so they monitored me pretty closely because I was like 5 minutes from the hospital. But I did go in, have the surgery, and I was in about, I think for like 3 or 4 days. I have 4 kids and my youngest was 1 when I had the surgery. And so they were like, oh, you can go home. And I was like, I don't know if I'm ready. I stayed, and that extra day they were like, oh, your creatinine's really shooting up, and they were able to do some things. So we could talk about that, but yeah.
But it's interesting. So it's quite different, the timeline, and now we've got a pretty extensive description of that initial portion of it. From getting back to life perspective, in the beginning you described this intravenous immune suppression that is pretty tough on the body. That means that I'm asking, does that mean that the first month or so, or even the first 2-3 months, that the person is more immune suppressed than in the second half of the first year? And does that continuously get more, so that the person can get back to being around people, is what I'm asking.
And so that's certainly, we do ask patients to take more precautions during the first month or 2 because that extra medication puts people at increased risk for infection and infectious complications. And as time goes on and the risk of rejection goes down, the doses of the medicine go down. You'll notice after transplant where we measure in the bloodstream we have these target levels for the medication. And so those levels actually drop sequentially at 3 months, 6 months, and a year. And that thymoglobulin is the name of the medicine that I was sort of describing, that wears off in the body. And so as that wears off, patients are allowed to do more and more. Now, we still actually want people to go outside and do things. For example, we send someone home after 4 days. We actually hope that they're able to, certainly by the next week, walk around the block, go outside and do things. Because in the open air, as long as there's not snow on the ground and you're going to slip and fall, you're very unlikely to pick up a
But
viral
not take the
infection,
subway or get on a flight.
Correct.
Yeah.
Right. And so we want people to go outside. We want people to be active. Their pain should be well enough controlled where they'll feel comfortable going for short walks. But being in the subway, being in a movie theater in a row next to or being where you don't know if someone is sick or not and they're going to sneeze on you, being in a crowded restaurant. For the first week, first 4 weeks, we ask our patients to avoid doing those things.
So what about the case, for example, Shelby's case? She's got 4 kids, mm-hmm. some of them young. Maybe they go to nursery school or daycare.
And they're all dirty. I know.
The germs, it's like little Petri dishes of germs.
That's a very hard situation because we want you to see your children. We gave you a kidney transplant so you'd have a better quality of life, a longer life to spend with your kids. But the people around you are where most of our patients get their virus infections, and it's where most people picked up COVID from. And so it's hard. Some places tell you not to kiss your child or your husband or wife for the first 3-4 weeks because they may be carrying some bug. But most of the time, beyond the first month, you can be with them, you can give them hugs. Obviously, if someone in the family is sick, they should stay away from you. Mm-hmm. And there are times when we've even, certainly within the setting of COVID, we were asking people to move to a different house. It depends on the resources that you have.
Wearing masks?
Shelby, I don't know. Routinely, no. But in the, in the setting of COVID, we were frequent, like people were coming from outside. We were asking them to wear masks in the house with our transplanted patients. But amongst their immediate family, like if I had a transplant and my daughter came home, I would not be wearing a mask around my daughter. Some of that is personal choice. There are some of our patients who were, because they're, for example, I know I had patients whose children were taking the subway in New York City back and forth to school during the height of the pandemic. And they had the resources to essentially like live in a separate attached house because the fear of contagion was so high. Pre-COVID, most of that was just.
Are there any animals that can give infections that one should pay attention to? I always hear birds are bad.
Yeah, birds are bad. They have all sorts of bacteria and things on them, some funguses. And so birds are pretty much a no-no for all transplant patients, according to our IDP, our infectious disease people. Cats also contain something, many of them have toxoplasmosis in their stool. Kittens in particular have something called cat scratch fever on their paws. And so we caution people against having kittens. Cats are, people love their pets. It's hard to tell someone to get rid of your dog, get rid of your cat. And so you can deal with a cat that's over a year old. You can change the litter with a mask and a set of rubber gloves and be totally fine. Dogs, we worry about 2 things. One is you get ahead of yourself and you try to walk the dog and the dog is pulling on you too hard, and that can hurt the incision if you're fresh after transplant. Dog can jump on your lap. It's not going to punch the kidney, damage the kidney, but it can be very painful to experience. And then dogs in general tend to have fewer infections and be less problematic. But yeah, birds can be a big problem with immunosuppression, and cats in particular with the litter box, and you need to make plans ahead of time.
Yeah, I will say that I don't have pets, but like I said, I had a 1-year-old. And so even changing his poopy diapers, it freaked me out. I don't know that it was a high risk thing to do, but there was all of that fear too about am I doing something that's too risky? And my son, I was looking back on Facebook memories a little while ago. He did end up getting chicken pox, a couple weeks, right after my transplant. It was right before he was eligible for that vaccine. Luckily I didn't get it, but it was just, there's some things you just can't take it. You can't plan for, especially with a bunch of little kids. The other thing, I don't know if you really talked about it, Dr. Crew, I had a lot of weight restrictions after my transplant, especially because I was a mom. I had, and 4 pregnancies, they told me that I could only lift 5 pounds for 3 months. So it was pretty extreme because I'm a small person too. Mm-hmm.
For the patients out there, you'll have to ask your surgeons what their required weight restriction are. Here we use about 20 pounds for a weight restriction. But you're right, we have 2-year-olds, sorry, patients who have 2-year-olds at home, 3-year-olds at home that want to be carried, and that can be really difficult. And then the duration of time is different again for each patient. 6 weeks, some people say 6 weeks, some people say 3 months, because of the risk of developing a hernia.
Yeah, I think that there's been some talk in the forum about hernias and like not knowing the risk of it as much like afterwards. I think you get so much information that sometimes things fall through the cracks and they don't realize like hernia can be such a complication sometimes.
Right. And it's a difficult complication. Fortunately for kidneys, it's not that bad. For for liver transplants, it is much more common just because of the nature of the incision. It does happen after kidney transplants. I believe about 2% of the time, between 2 and 3% of the time. It depends a little bit on if you get steroids or not, if you've been a smoker or not, if you're a diabetic or not. Luckily, I guess I'm lucky. I happen to work at a program that does not use steroids, and that kind of it makes the healing a little bit better, slightly lower hernia rates. But the hernia itself is uncomfortable, and then unfortunately the repair of the hernia is actually, they tell me, even more painful than the transplant operation itself. And so while most of the time the hernia is not life-threatening, it can be very uncomfortable to deal with, as well as uncomfortable to try to fix.
Something I hear often for individuals involved in transplant from a medical perspective, so transplant surgeons and nephrologists, they say it's one of the most rewarding procedure that you can do in medicine, because you have a person who may be on dialysis or maybe like you, preemptive, and like me, preemptive was still in pretty bad shape, and you get this new kidney, and then it is such a change. On average, Dr. Crew, I mean, do you see that the patients come back and just feel so much better, or is that the perception?
Absolutely, and it is. Obviously, there's a range of experiences. Compared to dialysis, dialysis takes so much out of people. The treatments themselves are very draining. The restrictions on fluid, restrictions on potassium, phosphorus, foods that taste good, restrictions on travel. And so transplants make people feel better. And obviously it improves longevity about threefold. That's why we do it. In the actual studies that have been done, I remember someone did this study like about 20 years ago where you pooled the population, like, how would you rate life on a scale of 0 to 1? So 1 is great, you're in heaven, 0, you might as well be dead. And apparently average healthy people will rate life about 0.8. Dialysis patients will rate it like 0.5, 0.55, and they'll rate a transplant 0.7. So patients don't get all the way back to having never been sick. But the quality of life is much better than dialysis. It's much better than living with a creatinine of 4 or 5, like stage 5 CKD. And so I think it is important, though, to keep kind of reasonable expectations of when you're going to achieve that goal, right? Or when you're going to achieve that level, because right after the transplant, it can be kind of tough. If you are having delayed graft function for 7 weeks and you're going to the clinic 3-4 times and they're adjusting the medicines and then changing this and changing that, it can be very frustrating and kind of, I don't know if demoralizing. I guess, Shelby, you can tell us whether demoralizing is the right word, but it can be frustrating because there are a lot of expectations and anticipation that, man, I'm going to have this, and tomorrow I'm going to be Superman.
Yeah. How do you feel about that, Shelby? I mean, what was your feeling in that first year?
Yeah, I mean, I think initially, like, it was just so heartbreaking because I was like, everybody on Facebook had been watching. I had just barely put out that I was looking for a living donor. I was 99% sensitized too. So it was a really big deal that they found a kidney for me. And I think everybody was kind of looking for that like fairy tale, like, oh, now she's great. I'm like, oh, I'm not okay. But I will say that, going through it, as I really did start to have to like lean into my body and to learn like how my body was processing it. Cause there was a lot of grief from like, just from kidney failure in general. And then like grief that it wasn't going exactly how I wanted it to. And then like really accepting that and then starting to have that healing process happen. I also had IVIG and, plasmapheresis afterwards because they weren't sure if it was a rejection or not. But it didn't look like a rejection. So they were able to take that off pretty quickly. But throughout that first year, I think that there was quite a few like hospitalizations and challenges. You said something a little bit about infections. I did get an infection. We could talk about that, but that landed me in the hospital. And so each time it was kind of like this trauma of like going back to the hospital. And it was like, oh, am I going to be okay? Is this going to be okay? And
Shelby,
my doctors had
was
told
that
me,
your fear? Was it fear of rejection that you had, or more the fear of just having to go back and be sick again?
I think the fear, well, because 3 days after my transplant, they came in and they were like, we think there might be something blocked and we might have to take the transplant out. So I think it was just a fear of like not having a kidney to replace it and not being able to find one.
Yeah.
But I think that they had told me about a year after it, like you start to get some normalcy. And that's when I went back to work, was a year after my transplant. And I really did feel like, okay, I'm starting to be normal. But like you look on some of the Facebook groups and people are like, oh yeah, I went back to work like 4 weeks later. And some people do. Like some people have a great experience. You just don't know what's going to happen. So that's that uncertainty that I think can be really challenging.
I have to say for me, I went back 4 weeks.
Yeah,
4 weeks,
lots of people.
But it wasn't perfect, 4 weeks. I did go back to work, but I was weaker. I was little, and more afraid. But it clearly was so much better than what it was before. But I think what is important is, and I think someone said this in the chat, it's not a cure, it's a treatment. Yes. And it's a continuous treatment. But it is a fantastic life-saving, treatment, because the alternative is not something we are wishing for anyone. But we do have to realize that it's a commitment as well. As someone who receives a transplant, we need to commit to taking care of this transplant, making sure we get our treatments and our visits, and that's tough sometimes because you have to think about it all. You have to keep it in your mind. And that's where we get a little bit to the mental health. Dr. Crew here, you're on your team. Do you see that people are seeking mental health support, or is that mostly done through support groups and places like TransplantLyfe?
We need more support, actually. Not to make this all doom and gloom. I'll say one more thing about physical recovery is that for most of our patients, some people go back at 4 weeks. Our average, I would say, is about 2 months until they get to the point where they feel like they're recovering on their own. And between 2 months and a year, every month people continue to have improvement in their endurance, improvement in physical strength, things like that. Psychologically, you're right, it is very emotionally burdensome. And our team we have several social workers that are available to give counseling, with a psychiatrist dedicated to give counseling. We need more support groups out there. Yeah, you mentioned TransplantLyfe. TRIO is another organization that provides a lot of support for patients. But there's not enough out there for us.
Yeah, no, I mean, speaking to people who have been through it and speaking to people who really understand, it's been very helpful, I think. And Shelby, you're one of the leaders in that space. So thank you for what you're doing.
Yeah, absolutely.
Any advice that we can give to those who are listening, who are on the waiting list, those who are just about to go out there and get a kidney, and that expectation, and just to not set it too high, but also give them hope. I think by just being here, we're giving them hope. But are there any little tips or tools that from both of your perspective that you can provide to our listeners?
Go ahead, Shelby.
I was just going to say, I was in such denial about the whole situation because I wasn't on dialysis and I felt really terrible, but I didn't know how sick I was. And there was almost this fear that if I found out exactly what needed to happen, then I would actually need to address that there was something seriously wrong with my body. And so honestly, I got the phone call and I was like, should I say yes? Because I had deluded myself into thinking this, maybe I can still heal from this. Maybe I don't need this. And so it kept me from finding more information. So it wasn't until right before the transplant, after I'd had my had the offer, that offer was 2 days before I actually had the surgery, that I was like, I should like go find out about this stuff. I should go find out what it is like to have a transplant and what happens afterwards. Of course, I'd been to all the appointments, so I had a general idea, but I didn't have any patient perspective. And I think it was really important to find patient perspective. I was like looking up YouTube videos of people that were talking about their transplant experience because I just didn't know where to go. And so I would encourage you, if you're on the waiting list, like, don't be afraid to ask those questions. And just because somebody maybe didn't have the greatest experience doesn't mean that you're going to have that experience. Everybody's very individual. And like, I look back and there was a lot of challenges that I went through, but I'm a better person for having gone through them. Doesn't mean I would ask for them again, but I've allowed that to change me into a person that I want to be because of what I've
Shelby,
gone through.
such a good point. Such a good point. I remember I had the same. I didn't know much about it. I knew a lot about it from a medical perspective. I knew very little about it from a patient perspective. And I was connected to someone who had gone through it. It was similar to me, also had type 1 diabetes also. And it was a terrible connection because everything had gone wrong for her.
I know.
and I was sitting, I can't do this. I cannot go through with it. And then I had another connection, and that was a much better experience for this person, but I was 1-1. And I think that it almost made me more scared. But since I continued and pushed to the next person and started to read about different experiences, it did help me. So don't be afraid if you see that one bad experience, because of course it happens, and every person is unique. And you also got to remember that, and this is something I was told, Dr. Kerr, by, I think it was Dr. Cohen, whatever statistics you look at now, it was what happened 10, 20 years ago, right? And everything we're doing is improving care and improving treatment. So whatever we're doing now should be better 10 years from now. So the statistics are, just showing a broad perspective. And it's also, as a person, we're 0 or 1. We're not, 50%. So that's important to consider as well.
I guess I would add, certainly ask a lot of questions. There's so much data that is given to people, and it is difficult to incorporate it all. And as a physician, I know sometimes I use medical ease, and I shouldn't. We're not always great at the data that we provide people. And then there's an entire onslaught in your visit, meeting 16 different people, and it can be hard to process. And so definitely, I would encourage people to continue going to seminars like this, go to YouTube videos. You come up with a question, email your coordinator, say, hey, what actually happens in the hospital? And I think my only two other pieces of advice would be having support available from friends, family, someone makes life so much better in the first 2-3 weeks, to not have to, even simple things, doing laundry. One day you don't feel well, you want someone to bring you over some food. Not everyone has that many friends or family around, but anything you can do to shore up the support beforehand just makes everything a lot easier afterwards, because for the first couple of weeks, you're going to need more help than you expect. Long term, you'll probably actually need less help than you expect. But yeah, it's that first really couple of weeks that were like that most people actually really struggle with.
That's really valuable. One more thing that I think is important is to take notes. For me, at least, a daily journal. Just to talk for yourself, because when you go back a week or two and you see, this is how I felt, you don't remember it, because I think human nature, that's why you have 4 children. You don't remember how painful it was with the first one when you went on, and not 4. But, you don't remember how bad it was in the beginning, and it continuously gets better. Of course, there can be hiccups, but if you see it from that perspective, you see that it improves, even though it's slow. I think you get encouraged by it. So that daily journal, those little notes, it helped me at least to get encouraged.
I would say too, take pictures. Like I did not want any pictures afterwards. And now my mom took a few, and I'm like, oh, I'm so glad I have those, because I was so sick. And now looking at how healthy I am now, I didn't realize what shape I was in. And so it's really fun. I'm like, I wish I would have had more pictures, because I did not want people taking my pictures at that time.
Yeah, a very good point. Yep. You don't want to have those pictures, but when you look better, then of course it's nice to compare. Yeah. Well, good. Thank you so much. This has been incredibly valuable. We've had so many great, comments here, mostly actually comments endorsing what you're saying. And there's more that we can talk about. The years afterwards, we're really focused on the first year. There's more that happens, of course, over time, because then you may have more of a problem with the graft, or you may have some, as you mentioned briefly, the infections and the rejection episodes and what you can do with rejection episodes. I think it was interesting that Dr. Crew was saying that some people, most people don't even know that they have a rejection episode, but that can be so dangerous over time. And we're really grateful to, companies and scientists out there that are trying to develop solutions for rejection, and also detection, markers, so that we don't have to do so many biopsies, kidney biopsies. Well, thank you. And thank you to our audience. And we'll see you actually next week, again, our audience, because we'll have another seminar.
Thank you.
Thank you so much.